Hello everyone, I am myself Dr. Rajesh Gubba, I am the General Medicine Educator. So in this session, I will be discussing a very important topic in the pulmonology, that is the pulmonary alveolar proteinosis. So as the word itself tells you that within the alveoli there is some protein accumulation. So that is what is the meaning of this word pulmonary alveolar proteinosis. So if you see the definition of this pulmonary alveolar proteinosis, first of all let me tell you it is not a very common disorder, right? It is a rare lung disorder, and in this particular disorder it is characterized by abnormal accumulation of surfactant derived lipoprotein compounds, right? It is characterized by abnormal accumulation of surfactant derived lipoproteins within the alveoli, right? So this surfactant derived lipoprotein which is accumulated within the alveoli of the lung will cause impairment of the gaseous exchange, right? Will cause impairment of the gaseous exchange. So that is what will happen in patients with the pulmonary alveolar proteinosis. You see here, this is the normal alveoli, right, where you have the air spaces wherein the air enters and there will be exchange of gases. But if you take in patients with the pulmonary alveolar proteinosis, there is buildup of the protein surfactant, right? You can see this white color, it is nothing but the protein surfactant which has been built up within the alveoli. And because of the accumulation of this surfactant derived lipoprotein within the alveoli, this will cause the impairment of the gaseous exchange, right? So this accumulated substance interfere with the normal gas exchange. And not only that, this accumulated material will also impair the expansion of the lung, right? It will also decrease the expansion of the lung. Ultimately, what will happen? This will lead to difficulty in breathing of the individual. And these individuals with the pulmonary alveolar proteinosis, not only they have difficulty in breathing, these individuals, they are prone for development of lung infections, because this surfactant derived protein, right, will be acting as a seat of infection. So they are more prone for the development of lung infections as well. That is what is your pulmonary alveolar proteinosis. So let me repeat once again. So it is one of the rare lung disorder. It is characterized by abnormal accumulation of surfactant derived lipoprotein compound within the alveoli of the lung. Now this accumulated substances, they interfere with the normal gaseous exchange and expansion of the lung, ultimately leading to difficulty in breathing and predisposition to developing lung infection. That is what will happen in patients with pulmonary alveolar proteinosis. Now, why does that occur, right? What is the etiology for the development of this pulmonary alveolar proteinosis? See, this abnormal accumulation of the lipoprotein compounds in the pulmonary alveolar proteinosis is mainly due to impaired surfactant regulation and as well as clearance, okay? So this impaired surfactant regulation and as well as the clearance, this is the one which will lead to abnormal accumulation of, right, which will lead to abnormal accumulation of surfactant derived lipoprotein. Okay, now what will be the consequence? Why does this impaired surfactant regulation and clearance will lead to this abnormal accumulation of surfactant derived protein? Why does this occur? See, this is usually related to impaired alveolar macrophage function. So it is the impaired alveolar macrophage function that will lead to abnormal accumulation of lipoprotein compound within the alveoli, resulting in pulmonary alveolar proteinosis. Okay, so that is a basic concept. The basic concept is due to impairment of alveolar macrophage function. So if you see in a normal individual, you have the mature macrophage, but in patients with the pulmonary alveolar proteinosis, there will be dysfunction of the macrophage, right? There will be dysfunction of the macrophage. Now again, the next question is, why there will be dysfunction of this alveolar macrophage? See, it is mainly because of impairment of the alveolar macrophage function. There is abnormal accumulation of lipoprotein within the alveoli, and that is the one which is responsible for impairment of the gaseous exchange. Now the question is, why does this impairment of the alveolar macrophage function occurs? So this is mainly because of the autoimmunity. Right, this is mainly because of autoimmunity. So in adults, the most common cause of pulmonary alveolar proteinosis is an autoimmunity to GM-CSF. So what does this GM-CSF stands for? That is granulocyte-macrophage colony stimulating factor. So autoimmunity to the GM-CSF. Right. So this GM-CSF, right, that is granulocyte monocyte colony stimulating factor, it is a critical factor, right? This is a very critical factor in the development of the alveolar macrophage, right? It is a critical factor in the development of the alveolar macrophage. So now the basic etiopathogenesis is what? Impairment of the alveolar macrophage. Why is that? That is because of the development of autoimmunity against the GM-CSF. And how is this GM-CSF and alveolar macrophage related? This GM-CSF, it is a very important critical factor in the development of the alveolar macrophage. So because of the impairment of the alveolar macrophage function, there is impairment of surfactant regulation and clearance. Now because of impairment of surfactant regulation and clearance, there is abnormal accumulation of lipoprotein compound within the alveoli, resulting in what is called pulmonary alveolar proteinosis. Okay, next. Now the other point that you see here, now because of the antibody formation against the GM-CSF, there is decreased bioavailability of GM-CSF, resulting in poor alveolar macrophages development and function, which results in accumulation of surfactant and its related products. Okay, next. Now we also have the secondary causes of the pulmonary alveolar proteinosis. Secondary causes of pulmonary alveolar proteinosis are those in which accumulation of lipoproteinaceous compounds is secondary to another disease process, right? So here also there is accumulation of surfactant derived lipoprotein within the alveoli, right? And why does this occur? Right? Why does this occur? This occurs secondary to other disease process. Right? This occurs secondary to other disease process. Now, what are those other disease processes which will lead to the secondary causes of pulmonary alveolar proteinosis? That includes malignancies such as myeloid leukemia, right, such as myeloid leukemia, then lung infections, then environmental exposure to dust or chemicals, right, environmental exposure to dust or chemicals. And what are those chemicals? These chemicals are, like, for example, nickel, Okay, so these are the secondary causes of the pulmonary alveolar proteinosis, and we have one more secondary causes of pulmonary alveolar proteinosis, that is GATA2 deficiency. So it is also a hereditary disorder, right? This GATA2 mutation, it is an autosomal dominant type of inheritance, and because of this GATA2 gene mutation, the individual can develop this pulmonary alveolar proteinosis, right? And it is an autosomal dominant type of inheritance. Now, if you see the signs and symptoms of pulmonary alveolar proteinosis, that includes, because there is impairment of gaseous exchange due to accumulation of surfactant derived lipoprotein within the alveoli. So, the individual will have dyspnea, that is shortness of breath. Right, so that is one of the very important clinical manifestation, right? And apart from that, the individual can also have cough, and there can be, right, and there can be low grade fever and as well as weight loss. Right, low grade fever and as well as weight loss. These are the signs and symptoms of pulmonary alveolar proteinosis. Additionally, the clinical course of pulmonary alveolar proteinosis is unpredictable. Right? What exactly is the clinical course is unpredictable. And what has been observed is spontaneous remission is recognized. Right? Spontaneous remission is recognized, and some patients, they have the stable symptoms. That is what you will see in pulmonary alveolar proteinosis. And if you see the complications, let me tell you, there can be even death of the individual. So, death may occur due to progression of pulmonary alveolar proteinosis or of any underlying associated disease. Right? So, death may occur due to progression of pulmonary alveolar proteinosis, right, or of any underlying associated diseases. Now, I said you that these patients, they are more prone for the pulmonary infections. So, they are more vulnerable to lung infections, right? They are more vulnerable to lung infections such as bacterial pneumonia, right? Number 2, Mycobacterium avium intracellular infection. Right? Mycobacterium avium intracellular infection, and then the fungal infection. So, these are the infections that can be seen in patients with the pulmonary alveolar proteinosis. Then, how will you diagnose this pulmonary alveolar proteinosis? See, diagnosis of pulmonary alveolar proteinosis is made using a combination of person's clinical symptoms first, right? And okay, combination of person's clinical features, then chest imaging, right? And then followed by that microscopic evaluation of lung washings or tissue. Right? Microscopic evaluation of lung washings or tissue. So this is how you can diagnose this pulmonary alveolar proteinosis. Now, apart from this, additional testing for serum anti-GM-CSF antibody. See, what is the basic pathophysiology? The antibodies are formed against the GM-CSF. So, you need to do the additional testing for serum anti-GM-CSF, right? That is granulocyte monocyte colony stimulating factor. So, these antibodies will also, right, these antibodies, they are also helpful for confirmation of the diagnosis. Right, these antibodies, they are helpful in confirmation of the diagnosis. And although both the symptoms and imaging findings are stereotypical and well described, they are non-specific and indistinguishable from any other condition. Now, let me discuss like what will be the chest imaging picture in these individuals. So, if you take the chest X-ray, it may show the alveolar opacities. Right, it will show you the presence of the alveolar opacities. And if you see the CT scan in these individuals, CT scan, it may show a crazy paving lung pattern. Right, it may show a crazy paving lung pattern. Okay, so this is what the CT scan in patients with the pulmonary alveolar proteinosis, right? So the diagnosis primarily depends upon the pathological findings. Chest X-ray, it shows alveolar opacities, and CT scan may show a crazy paving lung pattern, both of which are seen more commonly in numerous other conditions also. Which one? The alveolar opacities and crazy paving lung pattern, right? It is seen in many other conditions as well. Now, the other important way how you can diagnose is the bronchoalveolar lavage and as well as the lung biopsy. See, what you have to do is you have to take the lung washings or the lung tissue. Right, you have to take the lung washings or the lung tissue. This has to be taken for histopathological analysis. Right, this has to be taken for histopathological analysis. So this histopathological analysis is most commonly obtained using the bronchoalveolar lavage. Right, so how will you obtain this lung washings or the tissue? That is by bronchoalveolar lavage or by lung biopsy. Right, or by lung biopsy. And characteristic biopsy finding shows filling of the alveoli. So when you do a lung biopsy, this will show the filling of the alveoli. Right, this will show you the filling of the alveoli. And not only the alveoli, right, not only alveoli, sometimes even the terminal bronchioles are also filled. Right, sometimes even terminal bronchioles are also filled with amorphous eosinophilic material. Right, they are also filled with amorphous eosinophilic material. Okay, so this will be the very important multiple choice question, and as well as this will confirm the diagnosis of your pulmonary alveolar proteinosis. And this amorphous eosinophilic material, it stains strongly positive on periodic acid Schiff stain. So it will be PAS stain positive. Right, it stains very strongly positive on PAS stain and PAS diastase stain. So that will be the finding in the affected part of the lung. Whereas if you take the surrounding alveoli, right, if you take the surrounding alveoli, it remains relatively normal. Right, if you take the surrounding alveoli and pulmonary interstitium, that remains relatively normal. That is what you will see in the bronchoalveolar lavage and as well as the lung biopsy, right? So I'll repeat once again. Lung washings or tissue for histopathological analysis, they are the most commonly obtained using the bronchoalveolar lavage or lung biopsy. And what does the biopsy show? It will show you the filling of the alveoli and sometimes the terminal bronchioles with an amorphous eosinophilic material. And this amorphous eosinophilic material, it stains strongly positive on PAS stain and PAS diastase stain. Whereas the surrounding alveoli and pulmonary interstitium, they remains relatively normal. Right? Next, coming to the electron microscopic picture. Electron microscopy of the sample, although not typically performed due to impracticality, what does this electron microscopy of the sample shows? Electron microscopy of the sample, it shows lamellated bodies. Right, it shows lamellated bodies, and this lamellated bodies, this represents surfactant. Right, this represents the surfactant. Okay, and let me tell you what is another important differential diagnosis of electron microscopy findings having lamellated body. An alternative diagnosis with similar histomorphological finding is PCP pneumonia, right? Similar histomorphological picture is seen in patients with the PCP pneumonia, right? That is a very important multiple choice question, right? And if you take the lung washings, so whatever we have discussed until now was about the biopsy lung tissue, what it will show. Whereas if you take the lung washings, it characteristically yields a fluid, right? It characteristically yields a fluid which is milky in composition. Right, which is milky in composition, right? And under the microscope, the samples show 20 to 50 micrometer PAS positive globules, right? So under the microscope, what is that you will observe? The samples show (20 to 50 micrometer PAS positive globules, right? PAS positive globules on a background of finely granular or amorphous PAS positive material. That is what you will observe under the microscope. Okay, next, after having discussed about the diagnosis, so one of the very important blood tests which will confirm your diagnosis is anti-GM-CSF antibodies. And chest X-ray pattern, that is alveolar opacities. CT scan showing crazy paving pattern, it is seen in multiple other lung pathologies. That will not confirm the diagnosis. But the lung washings and biopsy can help you in confirming the diagnosis. Now, once the diagnosis is confirmed that it is a pulmonary alveolar proteinosis, how will you treat these patients? See, the standard treatment for pulmonary alveolar proteinosis is whole lung lavage. Right, it is the whole lung lavage and supportive care. Right, and supportive care. Now, what is the procedure for the whole lung lavage? Whole lung lavage, it is a procedure performed under the general anesthesia. Right, it is performed under general anesthesia, in which one lung is pumped with oxygen. Right, one lung it is pumped with oxygen, that we call it as ventilated lung. Right, that we call it as ventilated lung. And other lung, right, other lung which we call it as non-ventilated lung. Right, other lung, it is called as non-ventilated lung. It is filled with warm saline. Right, it is filled with warm saline solution. Alright, it is filled with warm saline solution up to 20 liters. Right, up to 20 liters. And this warm saline solution which has been filled in the non-ventilated lung, it has to be drained. Right, it has to be drained. And while draining, you have to remove if there is any proteinaceous effluent, if it is present along with it. Okay, so this is the ideal treatment in patients with the pulmonary alveolar proteinosis, that is the whole lung lavage and as well as the supportive care. Now, what are the other treatment options apart from the whole lung lavage? The other treatments still being studied include subcutaneous and inhaled GM-CSF. Subcutaneous and inhaled GM-CSF can be supplemented, right? And another important monoclonal antibody that can be given is rituximab, right? So rituximab, an intravenous infusion, what it will do is this will stop the production of autoantibodies. Right, this will stop the production of the autoantibodies. That is the advantage of this particular giving rituximab intravenously in pulmonary alveolar proteinosis. Right, and other one is your subcutaneous or inhaled GM-CSF can be supplemented. Next, the other modality of the treatment is the lung transplantation. Lung transplantation has been performed in individuals with various forms of pulmonary alveolar proteinosis. However, this is often only used when all other treatment options have failed. Right, so when all other treatment options, right, when all other treatment options have been failed, that is the point when lung transplantation has to be done. Right? Next, this lung transplantation particularly have to be done in those individuals who are fit for that particular transplantation surgery. So this is about the treatment options. So the treatment of choice will be whole lung lavage. The other treatment options are subcutaneous and inhaled GM-CSF and rituximab that can be given intravenously. Lung transplantation should be done when all other treatment options have failed and significant lung damage has developed due to risks, complications or recurrence of pulmonary alveolar proteinosis following transplantation. Okay, so this completes the discussion of PAP. So what is a basic pathogenesis here? The alveoli is filled with surfactant derived lipoproteinaceous material. And why is that due to? That is due to impairment of regulation by the surfactant itself. And why is that due to? That is because of the impairment of alveolar macrophage function. And why is that due to? That is due to the autoantibody formation against the GM-CSF. And the GM-CSF, it is a very critical factor in the performance of the function of the alveolar macrophages. So that is a basic pathogenesis. Clinical features will be difficulty in breathing and as well as cough. And how will you investigate these patients? You have to look for the anti-GM-CSF antibodies, right? And then the imaging studies and lung washings and biopsy will help you in confirming the diagnosis. The treatment is the whole lung lavage, and you can give the GM-CSF supplementation and rituximab can be given. And when the medical management fails, the lung transplantation can be done. So this completes the discussion of the pulmonary alveolar proteinosis. Right? Thank you very much.